I'm Andy Redfern. I'm a medical oncologist. I do some teaching, I do some sciencey stuff, and I do some Department of Health Services stuff as well. And I noticed in the questions that some people were asking in the run-up to the event that quite a few of those relate to services. This first talks about early breast cancer as billed. Going to look at various aspects to it. A reasonable amount of the latest treatments. Also, I'll be stopping for Q&A at about 3 or 4 different types in each section. And I've tried to, the questions I had sort of in the run-up, I've tried to put those on those slides so I can kind of address the questions I have so far. People are very welcome in those Q&A bits to ask anything they want. And I'll answer anything I know. Always important not to answer things you don't know, which some people try and do. So, I have learned. Getting into it, so I'm talking about navigating early breast cancer, and it is nobody expects to get it pretty much, and you go from getting some routine checks, all of a sudden you're a person with early breast cancer, and then it's this sort of conveyor belt / journey that you're on that you weren't expecting very shortly beforehand, and there's so many parts to it, so many stops along the way, and so on, there's a lot of stuff written on it now. This is me as a registrar, so I would have been about 30 here. Back then, there was about a research article on breast cancer about every hour. There were 5,500 in 1995, when I was first doing oncology. Last year is now finished, and 30,000, so I'm now reading one every 11 minutes rather than one every hour. So I'm now going to try and distill all of that into this talk. And Kirsten has locked the doors so nobody can leave, because that's probably a wise precaution. So it's too late now to sneak out. I've divided it up because there's lots of different treatments and they come in at different points, and so I find when you give a talk about a lot of different aspects of breast cancer, people can get a bit confused through entirely the fault of the speaker, because it's hard to work out where things are in the navigation through that. So I've turned it into a journey, looking at how we address those bits of the journey and the problems that can occur along the way. First, going to briefly touch on sort of the normal breast, because obviously if we can keep the normal breast normal, that's the ideal when we have no cancer at all. So that's prevention, obviously. So I'll talk a little bit about prevention, which obviously once you've got breast cancer, it's a bit late for prevention, but there's still prevention's important, because you don't want to get a second cancer. You don't want friends and family to get cancer. The next thing is this, the ductal carcinoma in situ. That's sort of pre-cancerous change, so there are some abnormal cells, but they're still within the breast, and there's a very low risk that it's gone anywhere else. And again, if you can catch things there, then it doesn't need any chemotherapy, often doesn't need hormones and lots of other things, just an operation. And that's where screening comes in. Screening and prevention are different. Screening is about catching something that's already happened, but at a very early stage. Prevention is about stopping it even occurring. The next point is sort of undetected cancer. A small cancer's formed, but it's not feelable. And again, that fits into screening. Are there better ways we can screen to find things when they're smaller? If we found a cancer, either not feelable or somebody's found a lump, and that's what it turns out to be, then once you've got a diagnosis of early cancer, then we're looking at the local treatment, about surgery initially. And then surgery, the surgeons are very good, and it's not usually a failure of the surgery, but there can be stray cells left at the site, and that's where radiotherapy comes in. And then finally, there's this concept that, and reality, that cells can move from the area more distantly before the surgery is done, microscopic distant cells, and that's where all these adjuvant treatments come in. After people have had surgery, they've had radiotherapy, some people may be offered chemotherapy, hormone therapy, things like HER2-targeted therapy, and so on. And so that's all about stopping microscopic distant cells becoming a problem. Then we've got the sort of the keeping an eye out for return, and what you do when you've had breast cancer. You've gone through all this treatment right at the beginning. You're now living your life, all being well, and then obviously there's always concern and monitoring to be done. And what do we do in monitoring? And also, what can we do about that sort of dormancy that breast cancer can have? And can we do something about that? Can we eradicate and stop those late returns as well? And all of this is about stopping the cancer becoming a late cancer with secondaries and having to treat that, which I'll be talking about afterwards. So we're trying to put roadblocks as early as possible. Obviously, we can put a roadblock here, but we want it as early in the road as possible to avoid the problem. So coming first to prevention, it's obviously important for the wider community, and it is possible to get breast cancer twice. One thing I would say, we often hear, patients often hear of people who've got breast cancer back on the other side, and that's actually a rarity. Most if people have been unlucky enough to get a breast cancer on the other side, that's almost always a second unrelated cancer. Some clever folk did some kind of gene fingerprinting on cancers, and they found when cancer came back on the other side, about 19 out of 20, it was completely different. It wasn't the same cancer. Very rare it was. So it's not a case of getting cancer back on the other side, it's just being unlucky and having a second one. And therefore, even if you've had breast cancer already, prevention's important because we're preventing a second illness. So we can put the blocks there. Obviously then, well, I will have to look for another job, but I don't mind that. There's other things I can do. How are we doing in WA for prevention? And we look at that by the number of cases, obviously. And this graph is, I haven't got too many graphs in, but this graph is how many, if you look at 100,000 ladies in a year, how many get breast cancer? And this is, as you can see, slowly climbing. Back in the mid-80s, it was about 80-something per 100,000. And now coming through to the last few years, it's been over 120. So about half as many cases again. So we're doing pretty poorly at prevention. Prevention's kind of stuck. We've not been making progress. It's been creeping up, and we need to try and do something about that. Is it because health is declining? There's more obesity. There's less exercise. Diet's poorer, and so on. Is it all those things? Well, that may be the case, but can we do something about it? And I think the cardiologists or those people that prevent heart disease have shown that you can. This is an American graph, and the red line is heart disease between over the last 20 years, and the blue line is cancer. And as you can see, heart disease has been falling, whereas cancer has not. So what can we do about it? Well, obviously, the first thing we look at is who's at risk, because if you're female and got breasts, then you're at risk. Males are at a very tiny risk. And generally, when we look at prevention, in order to concentrate our efforts where it's most useful and get the biggest gains, we look at who's at the most risk. So we're looking at trying to prevent it in the people at highest risk. And that's what they do in heart disease. They look at people with high cholesterol and they treat that. They look at high blood pressure and they treat that. Family history, smokers, and they're the people where prevention's focused. So we know some things about breast cancer. We know some lifestyle risk factors. These numbers are how much risk you lose, or it's improved if you do these things. So if you do the 5 and 2 versus 0, you knock about a quarter off your risk is what that number means. You get about 75% as much breast cancer, so less. So you knock a quarter off with fruit and veg. If you get about 3 hours of briskish exercise, and that's a brisk walk, it's not iron person stuff, then you knock about 20% off your risk. If you drink a couple of units of alcohol a day, you put your risk up about 14%. It's about 7% per unit. That's not 14% on top of, as the risk of breast cancer in WA is about 12%. That's not adding 14% to the 12. It's actually a relative risk, so it's 14% of the 12. So actually, in reality, it's about 1 or 2% of actual absolute numbers. And then if people are obese, particularly when they're postmenopausal, it adds about 50% to the risk of getting breast cancer. And it's certainly true that we've seen some worsening of some of these things. Here's a young couple, and I think we can see that there's some adverse health behaviours going on. I think that's a little bit of a pot belly there, though possibly at that age that's okay. Conspicuous consumption of alcohol, clearly a sedentary lifestyle we can see here, and also not a carrot in sight. Where's the lunchbox, I want to know. So certainly, but this is reflected in the older population as well. Obesity now in Australia is about 30%. It was about 8% in 1985. Certainly vegetable consumption has fallen away somewhat as quicker and more easy to access foods are available across the population. And exercise has certainly reduced compared to the 80s. My parents only had one car, and my dad, clearly mindful of my mum's breast cancer risk, took the car to work, even though it was only about 2 miles away. My mum walked everywhere, and so one for the team by my dad there. And whereas now everybody has 2 cars, or at least, if not more. So it's a rarity, and people are driving some ridiculous distances. I was actually out for a run, not that I run a lot, and I passed a couple getting into a car. A slightly large couple, it took them a while to get in, and I passed the car, and then I kept running, and I'm not a fast runner, I can tell you. And then I heard the car start up, and I thought it was going to come past me. I pulled in, and I kept running, and then nothing happened. And then I looked behind, and they pulled in about 6 houses down. I think that was their home. So that's the kind of thing we're seeing, and it's certainly we're encouraging our patients to increase that, both in prevention, and that's the role of the GP essentially, and public advertising. As an oncologist, I ask all of my patients, I ask how the tamoxifen is going or whatever they may be on. I also ask how much exercise they're doing. Beyond those lifestyle things, there are some risks that are somewhat harder to, those things we can change. There are other risks that we can't change. This is one that's come up recently. You've probably come across the concept of mammographic density. And mammographic density is basically just a simple description of when you have a mammogram, how white it is. You can see the picture on the left is a very low density breast, and the picture on the right is a high density breast. These are normal breasts. This isn't disease. This is just the natural person. But the low density breast, the risk of breast cancer goes up as breast density increases. About 5-fold. So this probably translates, if we look at somebody who has low density breast, their risk is probably 4 or 5% lifelong. Somebody with high density breast is probably more like 20-25%. So that's where the absolutes come in. Clearly, if we identify people with higher density breasts, then that's somebody we might be targeting for prevention. And these things, we can get an overall figure. This incorporates mammographic density. This is a very recent risk score. You can do it on the internet. It also incorporates things like family history, age, whether you've had benign breast conditions, whether you've had previous breast cancer. Your ancestry as well can alter things. And so we can put those factors with mammographic density and come up with a risk. This isn't done, though, routinely. So we have a lot of this information, but still everybody's getting mammograms every 2 years, basically. Invited 50 to 75, and certainly very welcome to ring and make an appointment from 40 onwards. So I think we certainly, when we've found somebody with risk, we can do something about it as well. We can obviously prevent those lifestyle factors. We can improve exercise, improve vegetable consumption, reduce proportion of people that are overweight and so on. We also have some drugs, though we prefer to go natural if we can. For example, there's some trials of tamoxifen, and this is risk reduction in people who have got a high risk of breast cancer, 25%, family history sometimes, or other risk factors. You can see these red bars are how much you reduce breast cancer, anything from 1/4 to 1/2 off your risk with tamoxifen. Another trial compared tamoxifen to a sister drug, and they were very similar, knocked about 1/3 off the risk. And then the aromatase inhibitors, many people will be familiar with through preventing return of breast cancer, exemestane, letrozole, and anastrozole, they knock 2/3 off the risk in postmenopausal women. So if we identify people at risk, we could then potentially offer those people, when they've been identified, these medications. We've also found if these drugs, we give people them and mammographic density drops, then your risk of breast cancer drops substantially. If mammographic density doesn't drop, then they don't make much difference. And I think one of the reasons that we've failed where cardiovascular disease, heart disease has succeeded is they're treating measurable things. They're treating blood pressure, they give a pill. You can see the numbers better, so people know it's working. Cholesterol falls to a normal range, you know it's working. And if we can do things for breast cancer risk where we can measure something like mammographic density, show that an intervention's working, that is far more encouraging to continue with it. So finally, in the prevention, an evolving strategy we could look at is actually doing a mammogram on everybody at 40. This is a thing we're working through, and there are actually now a couple of trials looking at this, just to get mammographic density. Doesn't mean we then screen everybody. Do a model, one of those risk things, combining all the risks. If people are at low risk, just some general education on prevention, no interventions. Well, if we get those people at really high risk, we might do very specific intervention, addressing risk factors. We might offer anti-estrogens and monitor them based on density. And hopefully then we can start getting that curve coming in the other way. So that's the prevention thing. Now I'm going to turn to probably what most people are interested in, the main, which is when you've had breast cancer and it's early, what can we do about it? So cases are increasing, but if you're unlucky enough to get breast cancer, how do you do? How is survival going? Thankfully, this is it's not a dramatic curve because it's a bit all at the bottom, but mortality is actually dropping. And as the cases are going up, and actually survival is improving still per 100,000, even though there's more cases. The way it works is I've made the calculations, done the math. And this is not 5 years, as many of the figures are. You'll see that breast cancer's got a 91% 5-year survival. This is more the lifetime of the disease, so this is longer survival. And it's gone from about 69%, this is about 10 to 15 years out, up to 86% at the most recent measure we got to about 5 years ago. And we believe, the other thing to remember about these figures is people who die of breast cancer usually got it several years ago, so there's always this lag. So these are people that are treated for their early breast cancer several years ago. So actually we suspect the results, even if we don't do anything else, will improve. I've worked in a good few places. I trained in Scotland. I went down to London. I went up to Newcastle. I then went to Auckland for a while. Then was in Melbourne, and now I'm in Perth. And one thing I've noticed is everybody has a sense that maybe treatment's a little bit better somewhere else. Certainly in the UK, people are thinking, oh, maybe in those sort of more up-to-date modern countries like Australia, America, maybe treatment's better. Here in Australia, people go, oh, maybe in the sort of the big universities where the original seats of learning, maybe it's better in the UK. Certainly, I'm thankful to say that you can't really do better than Australia. That's been studied across 20 countries, and Australia did the best, better than the US, better than Canada, better than the UK, better than France, better than Scandinavia, better than everywhere else. So Australia's pretty good, so should you go east for your treatment, then that's a question. And this is a calculation. This data is about 9 or 10 years old, but it shows how we're going in terms of getting to 100% survival across the states. And obviously I might not have put this up if WA had been at the back, but certainly other than the ACT aren't at 100% actually. They're just ahead. They're at about 5 years. They're at about 93%, and WA's at 92% with Queensland. The old money in New South Wales and Victoria are a little bit behind, it has to be said. So certainly staying here is a reasonable choice. So moving from prevention and general survival, we've seen survival's improving, so why is that? I think screening is one of the two answers. The two answers really are screening and then the adjuvant treatments, all those precautionary treatments we give people who have had breast cancer to try and stop it coming back. So looking at screening first, screening was first brought in as a routine in 1989, and 10% of cancers were being detected by screening in that first year, and it's come up to 40%, and it's about that in 2018, I think the last time we've got full figures. Because not everybody goes for mammography, because they're not in that age category, not everybody chooses to go, is in the age category. And screening is about 85% to 90% pickup, not 100%. What does this do to that? Why does that improve survival? Well, there's about 500,000 women agreed to go on screening trials, either being screened or not. And being screened in those women reduced the risk of breast cancer deaths by about 20%. So that's, we've seen about a halving of mortality, and about a quarter to a third of that's just due to breast screening and mammography. Now, obviously, we're already doing screening. We might be able to target screening more, but we're already doing screening. There's a lot said about the other tests that we can do. The left picture is an MRI and the right picture is an ultrasound. The left picture is a small breast cancer in a young woman with high density breasts. An MRI is now funded. No small part to the efforts of Christabel Saunders, who was in Perth and is now in Melbourne, who got established that as a funded item. And if you're young with a risk of breast cancer, you can get funded MRIs. Ultrasound also can be a useful adjunct, and this is an ultrasound with a breast cancer there. If you've got low, breast density is probably pretty important there again, so if you've got low density breasts, ultrasound adds almost nothing, because the mammogram's a great test. You can see very early on small areas of density. Whereas if the breast density is high, mammogram drops from about 90% to about 60%, and ultrasound gets it up to the middle 80s. So what I do is, certainly in my clinics, if you've got high breast density, I arrange an extra ultrasound. If you're at the bottom of the density range, then that's not necessary. So I talked about a prevention strategy. We can also add, we should probably not just be working on prevention, but also tailored screening. Again, we don't, if somebody's an athlete, non-smoker, normal cholesterol and normal blood pressure, we won't screen them for heart disease, and the same goes for breast cancer. If you've got low risk factors and a low breast density, then maybe you just need mammograms even from later than 50 and maybe just every 3 years. If you've got high density breasts, maybe the screening should be done every year or every 18 months, and maybe we should add an ultrasound routinely. And trials are now going on adding these things into routine mammography. It'll take another 3 or 4 or 5 years, I think, but hopefully we'll see some tailoring, so it's not just a one-size-fits-all approach. And hopefully then we'll see both the prevention and even bigger improvements in the survival. So next on the road, we've found a cancer. Might have been by screening and it was undetectable. It might have been a lump. So what about surgery? How's surgery been coming along? Surgery has really been more or less the same since about 1890, the Holstead mastectomy. It was a more aggressive surgery then. The muscle on the chest wall was removed, lymph nodes, and even bits of nerve were sometimes removed, and it was very debilitating. Really how surgery has improved up till probably 1980 when it probably reached its, when we started to do more lumpectomies and sentinel lymph node biopsy started to come in. It's now been minimalized to a pretty substantial extent. So surgery's been getting less and less to try and each time we lessen it, we check that still gets the same results, and then we're good and it becomes a lesser thing. Sentinel lymph node biopsy is going to mention because that's probably the thing that we now do that lessens problems the most. If you're not familiar with sentinel lymph node biopsy, this is where the surgeon injects some dye, and it's a mixture of a blue dye and a weak radioactive dye, are either around the lump or around the nipple, and then when they look at the lymph nodes, they use a radioactive probe to find the hottest spot, and then they make their incision over that hot spot, and they look for blue lymph nodes and they remove them. And they just remove the blue lymph nodes, and the idea is that they're the very first lymph nodes that lymph goes to, and any cancer cells will go there first. And if that lymph node is clear, then the others are very likely to be clear. And it's about 99% if you've got a clear sentinel lymph node biopsy, then you're good with the other lymph nodes. What does this do? Well, it reduces the, this isn't that these things, something's happened to my graphs, but these are, this is showing the reduction in proportion of things that happen. So if you have sentinel lymph node biopsy, the risk of infection in the area goes down by almost a half. This is pain, and the risk of pain goes down by 50%. This is seroma, the risk of seroma goes down by 60%. And then this is numbness, and the risk of numbness because of not damaging nerves go down by 75%. It's not that these things are 100% with axillary clearance, but this is a proportion improvement you get. Obviously, lymphedema is the one that most people are concerned about, and it's an unpleasant, debilitating thing, and it really can affect every aspect of your life if you get it severely, and it's best avoided. If you have a lymph node clearance, about 16%, and it drops by about 2/3 if you have a sentinel lymph node biopsy. There is some there now, and we're actually even now with our early chemotherapies that are more effective, even trying to work out whether we can avoid sentinel lymph node biopsy or even avoid lymph node clearance when sentinel lymph node biopsy's got one lymph node involved. So that's, I'll pause there. That's sort of the local treatment. These are some of the questions that I received in the run-up to this. So I was going to run through those, and people are very welcome to ask anything. I'll be talking about chemotherapies and hormone therapies. I'll be talking about survivorship in the later parts of this talk. So if there are any questions about surgery or diagnosis or prevention, then I'm happy to take them. I'll just run through the questions I have, though. I'll paraphrase these somewhat to make them into a question, because some of them are sort of statements. So does a mastectomy mean that cancer will not return locally? It nearly does. The risk of cancer return is about 3 or 4% generally after a mastectomy. If the breast cancer was bigger, 5 centimeters or more, there's a slightly higher risk, and that's when people are often off radiotherapy even though they've had a mastectomy. So generally a mastectomy almost clears the risk, but it's not 100%. It's probably 3 or 4% risk remaining. The other thing that's often asked is whether people should have, they say, I've not got breast now, I've had double mastectomy, so I can't have mammograms, what test do I need to have? Now, ultrasounds can be done, but there was a study looking at about 2,000 women, and ultrasounds only found some kind of return about 2%. And in, I think, every single one of those women, the nodule was already apparent, and was either they were aware of it or it had already been found. So the risk is very low, and actually detection by examination, keeping an eye on the area yourself, by your oncologist of whichever brand of oncologist you have looking after you, checking it's actually better than an ultrasound. If you don't look at the area and do an ultrasound, that's not as good as physically checking. Can cancer return under implants? That's a concern that a lot of people have in going for reconstruction. What happens if the cancer's hidden when it returns? Actually, the implants are usually subpectoral, so they're under where the breast tissue used to be. So it very rarely occurs, but I've seen about one case, I think. So So it's very rare, but it can occasionally occur. If people get symptoms, certainly we do an ultrasound or MRI of implants, but that most commonly shows either an implant rupture or those kind of things. So it's a pretty safe thing to do. It's a rare thing for it to return because where the cancer was taken from was above where the implant goes in. How do you then screen for a return after double mastectomy? And that's the ultrasound question I was talking about. Obviously, we keep an eye on everywhere else. Some people, when they have double mastectomy, say, I'm puzzled as to where I've been offered chemotherapy because now I've got no breasts. Surely there's no risk, and that's obviously because we're concerned about those stray cells. The other question is if, say, you're certainly patients who have BRCA, they often have a double mastectomy because there's a high risk of breast cancer. And the double mastectomy reduces the risk by about 95%. So you've got a 1 or 2% chance of getting breast cancer because there are occasional small areas of glandular tissue that weren't part of the main breast. It's a rarity. Your risk goes down to lower than the general population, but it's still being vigilant if there is a lump, getting it checked out is still important. It was brought up there's a lack of choice in local breast surgeons. And that was mentioned 2 or 3 times. That's a tricky one. We can make sort of resources available, but choice of sort of where people operate is entirely obviously with them. There are obviously moves in medical schools to try and sort of encourage training students and doctors to work in areas where there are less resources, but by the time people get to being a consultant surgeon, then even if they were on one of those programs, they've expired. And we found a problem both, it's not just that there is a lack of choice or even not a breast surgeon, but it also fluctuates. You find out who it is and you educate people about that local surgeon, and then they move, and then so that's also a problem. So I don't have an answer to that one beyond we promote and try and encourage people to work. Even if it's provide resources to people even to come to the area and do an operations for 1 or 2 days a week. But choice, obviously, beyond actually having a service is even harder. So I'm sorry, I don't have an answer for that one. Other than we encourage it, we try and encourage people to do at least some time in areas where there's not much choice. And again, not enough knowledge about local GPs, about surgeons. We have tried to maintain a register, which is for GPs. We had some pretty extreme examples which led to us looking at that. I had a breast surgeon who'd worked in the East, and he was actually doing a locum in Kalgoorlie where there wasn't usually any breast surgery. And not Kalgoorlie, sorry, in Broome. And so he was a perfectly competent breast surgeon, but he didn't know any connections. And we found he was referring the few patients he did when he referred for radiotherapy, he was referring to Queensland. So. And we found a patient who had to go and get a hotel in Queensland, even though a family lived in Perth, which is very poor, really. I mean, it's a little bit lazy. You should be looking at and finding local resources. But that was what triggered us to try and make a network. We have found, though, in the regions that there's quite a high turnover. And so we found that within a couple of years, our registry is out of date, but we try and do what we can with that. There is also the breast surgeons of Australia and New Zealand have a registry, so we try and make GPs aware of that. And you can put in details of where you want to work, and I think patients can do that too. And you can potentially hint to your GP they might try such and such a person. So they're the questions I had that are in this area. Does anybody else have any other questions just in the surgery space before or prevention or screening? Yeah. Yeah. And I've asked around, and sometimes you just feel really tight. Yeah. Mm-hmm. And I asked regularly, a person that you know very well, is there now, can you have the implant on the outside of the yeah. Apparently they are doing that now. Yeah. Mm-hmm. Can you comment on that? And is there in the exchange later on, after you get to, having a new set put in, can you go back from having your pectoral muscles stretched out to then going to the implant just on the outside? I think one thing to bear in mind, I'm not a breast surgeon, so I see what they're doing, but the reconstruction is often done by plastic surgery, so it's not the area I'm most familiar with. Certainly I know they are siting implants somewhat differently because there is this tightness, and some people have to have an operation to remove their implants just because they're too tight and painful, and that's obviously a very poor result. So they are doing that somewhat. I think the subpectoral is still preferred, not because of recurrence, but for cosmesis and the ease of the operation and other side effects around thinness of the skin over the implants and things of that nature. But they are doing it sometimes. It depends a little bit on the person's tissue, so to speak. Yeah, that's what the plastic surgeons talk about beyond the details of that. They certainly do. They try and do, and it's usually a physio thing rather than a surgical thing, but they can remove tight tissue and scar tissue as well. So they do that. It's pretty unusual that they do that, because another operation, everybody scars differently. So sometimes the tightness is due to people vigorously scar, and even when you try and remove scar tissue, you just get the same problem again. You've seen occasionally people get that kind of keloid scarring where they just have even if they get an incision on the skin, they get really thick, bulky sort of scar, and other people heal beautifully. And those people that get the keloid scarring internally as well, they're more prone to that kind of stuff. So they certainly sometimes revise things, but they have to bear in mind that it might be part of the natural healing process. So they certainly are moving them to different places depending on the tissues and whether they feel there'll be a tightness problem. But I couldn't comment on the exact things they use to choose that. But that depends on brand. And again, I see lots of people who've got implants, and I refer, if there's a problem with them, to the original surgeon. But it is extending. Obviously, there's been these implants that cause that irritation that's got that low but existing risk of a lymphoma, so a lymph cell cancer under the implant, and they are now being monitored or changed. There's plastic surgeons deal with those programs. So it's certainly extending. I think I just saw a single figure, and this is just from the literature, it's not from my personal knowledge, seeing lots of patients who have needed to extend them, that the life has gone from sort of 15 to 21 years, and that's, lots of people have 40 years, obviously, but yeah. Yeah.
With dense breasts,
Yeah.
if there's no, so my sisters have got dense breasts.
Yeah, sure.
Breast cancer, but they
Yeah, sure. Yeah.
would they consider giving them medication like anastrozole or something like that before, without being diagnosed?
Yes, those little bar charts, coloured bar charts, they're what we call primary prevention. So that's, you've never had breast cancer, but you've been established to have a risk, and you take it to prevent it. So that's what those are about. So that was exemestane, that blue bar, which is the most mature study, and that knocked 2/3 off the risk. And that was taking, at that stage, because it was run a while ago, the awareness of density wasn't up. There are now studies looking at dense tissue, but yeah, it might be, you could use that model, you could put their density in, and you could put the fact that they've got a sister who's had breast cancer, so that's first degree relative. Look at other factors about themselves as well, and they might score pretty high on the risk, and it might be very reasonable to consider one of those medications, yeah. And that's not done routinely, and I think that's what we need to work towards, yeah.
Can I just make a comment? If sisters have really dense breasts, it would be recommended that they actually have a contrast-enhanced mammogram rather than a standard mammogram, and it's easier to actually detect things as part of the screen.
Thanks, yeah. There are another, certainly, now Breast Screen WA, as many will know, may have had these letters, even sends a letter to people that have got high breast density. There's not lots of technical information and numbers on it, because they recommend that you may be increased risk of, I think they tell you maybe a mammogram may not be as effective in detecting cancer, and you consider going to your GP and having examinations and possibly other tests. That's Breast Screen WA is about 9 years ahead of the rest of the world. We've been doing it for almost a decade, and then there was some cases, some legal case in America, and it's become mandated in America, and it's starting to be done across Australia now. But Liz Wiley, who runs Breast Screen, she's a decade ahead of everybody else in reporting this, and we're starting to look at what people did with that information as well now, when we told people that. And we hope to have trials showing, yes, you should have an ultrasound as well as a mammogram. We're thinking that might work. We haven't got a trial that shows that yet. So Breast Screen are not funded to do other tests at the moment. If you go to Breast Screen, you can only have the standard mammogram because they're not allowed to do other tests. But Liz, who runs Breast Screen, is very much hoping that these trials will free her up to personalise the screening, but other screening tests should be considered, yeah. I might address that question later on because I'll be talking about that, yeah, but probably 5 to 7 years or 5 to 7.5 years is the answer. Lower risk, 5 years. There's been lots of extension trials, but probably 7.5 years has been probably shown to be about the peak. But I'll come back to that a bit later. Yeah.
My question is in relation to some here medically quiet, can only have the surgery may only be medically necessary, depending on public, private, whatever position they're in, and
Right.
then further down the track, it may appear elsewhere on the other side, so many years down the track. Does that show up in your statistics when you're looking at secondary? Just looking at your roadmap.
Yeah. Mm-hmm.
Yeah.
So, I mean, as I mentioned, if it's the other side, then it's usually a second cancer, the rare instances where it's not. So they've been unlucky and got breast cancer twice. The risk of that in somebody who's had breast cancer over the next 10 years is about 3 or 4%. If you're actually on a anti-estrogen, then it drops to more like 2.5%. If you actually have chemotherapy, your actual risk of a second primary goes down. So if you've got a low-risk breast cancer that doesn't need chemotherapy, compared to somebody who's got a high-risk one where you have chemotherapy, your actual risk if you've had chemo of getting that second unrelated cancer goes down, probably because we eradicate stray cells. But the rate's very low, so we don't recommend routine mastectomy on the other side because it's potentially 2% in people are getting other treatments. And there are these risks of side effects, numbness, infection, seromas, lymphedema, and so on. When you do the operation, it's a smaller operation if it's preventative because you're not needing to remove lymph nodes. But so that's why it's not recommended routinely, because first you can screen for it and usually cure it when you find it. We cure over 90% of second cancers. And secondly, there are side effects. So if you do 50 mastectomies to find one cancer, and then you can also cure 9 out of 10 cancers, you're looking at doing 500 mastectomies to actually prevent somebody dying of breast cancer, which is a lot of operations with a lot of risk, and that's why it's not routine. However, usually in public you can have a double mastectomy if you choose to. The surgeon doesn't dissuade you because of resources, it's because of that 500 operations to make a difference to one person. So I don't know about private in terms of whether private healthcare fund double mastectomies, but you can say it's a medical need, it's not a cosmetic need, it's still a risk. But so I don't think in most places, it's not resources more that it's the recommendation not to do that because of the risks outweighing the benefit. Does that answer the question?
It does. It's just I was thinking about my experience and my friend's experience, and we had very different journeys. And she's still, even though mine was done and dusted mastectomy reconstruction, which was great for me. I had the option and I was given the choice. She wasn't given the choice. It was told, this is what is medically necessary, this is all we can do for you. And now she's come back so many years later and she's had to have the treatment on the other side.
A second time, yeah. So she was keen on having a second mastectomy,
she
but
wanted
wasn't
that
allowed to. Yeah.
because my journey was different. She said, how come I can't have what you've had? So
I mean, the one thing to say about medically necessary is if somebody wants an operation that the surgeon doesn't think is going to have any benefit, then they'd be negligent to agree, even though somebody may want it for a perceived benefit. But there is a small benefit here. It is that small figure. But so I think it may be that the surgeon's saying there's no benefit, meaning that the benefit is not as big as the risk. But it's not true that there's not a benefit. And most surgeons will counsel people and give them those figures. But some people are very anxious and they just live in fear, and that's crap, obviously. You don't want to be doing that. So they will do an operation if they perceive that there's a psychological benefit, and that's still a big benefit. Maybe the main benefit, obviously, but they'll still do it. They will counsel against doing it routinely and orientate people to those figures, but if people go, look, I'd rather have it even if it is only that small risk, then they'll do it usually. But then surgeons are very individual and they're more varied maybe than we are, and that some are great and some are very, this is what I think should happen. Yeah. Okay. Thank you for those questions.
There's about 15 left.
15 minutes. Okay, I better get moving. We're about a quarter of the way through. So.
We'll come back, Roz, because we're just conscious
Yeah. So, next, radiotherapy, which is a relatively brief segue, but radiotherapy, the routine is if you have a lumpectomy and radiotherapy, that's equivalent to a mastectomy. And there's now trials going out about 40 years showing that they're exactly the same for the majority of people, except very high-risk cases where radiotherapy may be offered after mastectomy. What we're now looking at is, does everybody who's had a lumpectomy need radiotherapy? Can we de-escalate that? Firstly, we look to whether we can reduce the treatment length, and then even down to a single treatment in some studies, and then are there patients we can identify to leave it out entirely? So there are a number of trials, and I'll just show you a little bit on the target trial because it was done in WA substantially as well as elsewhere. And this is where you get a single radiotherapy treatment. So the breast mass is removed, and the grey star there is the tumour. You get a cavity, and then this thing you can see on the left, that's inserted into the cavity, and that delivers a single, relatively high energy but low penetration beam. So it doesn't go out very far, but it does give a good dose to the surrounding area. The question is that better than coming for 6 weeks and having radiotherapy every day externally? And that's obviously got, if it's as good, then it'd be great for certainly rural and remote communities, and also probably be a lot cheaper to do in terms of resources. So this study was done, a single treatment of radiotherapy versus about 6 weeks on average. And this is what's been found at about the sort of 6 or 7 year mark. Local cancer returns did go up a couple of %, so it was about 1.5 compared to 3, so there was a slight increase. Breast cancer deaths went up about 0.5%, so there was a slight difference, though very low in both groups, as you can see. However, non-breast cancer deaths were substantially lower, and in fact, overall, there were less deaths when you got this single radiotherapy fraction. And this is because radiotherapy can have a subtle effect on the blood vessels of the heart and cause some micro scarring and narrowing, and so it increases the risk of getting heart disease. It's not a high risk, as you can see, a couple of %, but it still means that the benefits, the small risk of increased breast cancer events is outweighed by the benefits of lower toxicity. This is not done routinely at the moment, and this is a longer-term outcome showing that, in fact, at 12 years, in fact, it goes even further apart. There's almost still just that 0.5% difference in breast cancer deaths, but the heart risk had risen to about 5%. The women in this study were pretty low-risk breast cancers. They were over 50. They had less than 2 centimetre cancers. They were all ER positive, estrogen-driven, and lymph node negative. And so those patients with that profile are considered if there's the equipment's available locally. But we don't do this technique if it's a lobular cancer, which can stray a little bit further from the main area, if those higher risk HER2 positive and triple negative cancers, and also BRCA patients where there's a risk of breast cancers elsewhere as second primaries. So that's the first thing. So certainly we can de-escalate, and we're now doing trials looking at high risk people, see if we can de-escalate even in there. Also, then the Prospect trial, this was done by Bruce Mann, a surgeon in Melbourne. So this is an Australian trial, and he was saying, can you actually leave radiotherapy out in certain people? And the Prospect trial did this, and it looked at the type of cancer and also the MRI. His trial looked at, it's just a single arm, it didn't randomize, so just looked at 344 patients, so everybody was at least 50. And then the MRI had certain low dye uptakes. The dye in the cancer was very focused, and it wasn't spread broadly around. There weren't triple negative cancers, and there weren't lymph nodes involved. And at 5 years, with no radiotherapy and a lumpectomy, he found that there was only a recurrence in 1% of patients. Not everybody's got to 5 years, it's about 2 patients. Regional recurrence, meaning a bit further away, was 2%, and that probably is second, that's DCIS included. And actually, distant breast recurrence, there was only 1% of people who got that. That doesn't mean if they'd had radiotherapy, that wouldn't have happened. So these patients are at very low risk generally, and without radiotherapy, and there was nobody died of breast cancer. So now I'll move on to talk about adjuvant therapy, and this is all the preventative treatments you get after you've had your operation. This is the first sort of attempted adjuvant therapy. This is 100 AD. This is Galen, and he burnt some river crabs, odd numbers. I don't think he did a trial comparing even and odd. I think He liked odd numbers, Galen. He mixed the remains with cyprian oil and applied as a lotion with a bird's feather. And this was to people who had breast cancer, and he applied to the breast and to other areas around. And this showed he already appreciated breast cancer could be a systemic disease. We don't use this recipe anymore at Fiona Stanley Hospital, but I believe it may still be in the protocol book at Charlie's. I'm not sure. Not really. If anybody who treated Charlie's is absolutely fine. Now, when we look at prevention of return, obviously we know Galen knew there was breast cancer. He didn't know anything about subtypes, and now we don't just consider breast cancer as one beast, but a number of different kinds of beasts. And we look at the cancer tests under the microscope. We look for estrogen receptor signaling, so it's a hormone-driven cancer. We look at this other thing. HER2 is a growth factor that circulates in the blood, and it can also has detectors on some cancer cells, and they can use that to grow. And we also look for HER2-positive cancers. We look at this in every cancer. If you don't have either of the two things that show you're a hormone-sensitive cancer or the HER2, then you're a triple-negative cancer. So I'm going to show you a case report just to sort of illustrate the benefits and the added bits we do. This is a case report for somebody who's pretty high risk, but also they're also an estrogen-driven and a HER2-driven cancer, and that's not particularly common, but the two systems can occur in a person. So this patient's a 41-year-old lady. She had a 2.5 centimetre cancer, grade 2, so those are both medium, but there were 4 lymph nodes involved, which makes it higher risk, and certainly with HER2-positive and lymph nodes, that becomes very high risk. Certainly back in the day before we could treat the HER2 element. So 10-year risk, if we did nothing but an operation, is about 75% for cancer return. So what do we do about this? And we do quite a lot of things. And this case is because of both systems there, she would benefit from almost every treatment we have to offer. This kind of makes oncologists look good, to be honest, but it also illustrates all the tools we consider using. So my graphs have shrunk on this computer. I don't know why, but anyway, not to worry. So for basic surgery, then we've got, yes, it's done very funny things. That's 25% anyway, so that's if we just did an operation. We then look at standard chemotherapy. Many people will be familiar with the red devil, adriamycin. There was a group in the 60s in Italy that decided for some reason that there could be anti-cancer substances in the soil, and they were actually right. One of the most active drugs still for breast cancer is adriamycin, the red devil. And this is the castle where it was first discovered in the soil around. If we give adriamycin for 4 cycles, then we see about a 15% benefit. So the risk becomes about 60% for return, not 25%. We then added more recent drugs. We found taxanes, which are drugs, they're the ones that can give you tingling and numbness in the fingers from yew trees. And we add those after the adriamycin, and we find that gives you a further 10%. So with that double type of chemotherapy, we're now about 50% cure. We now accelerate the chemotherapy. Many people who've had chemotherapy will remember you get that little injection in the tummy, under the skin, that boosts your immune system. It can also make you feel like you've got a really bad flu and make you feel really achy. That's called GCSF, and that boosts these cells, which are your neutrophils. They defend you against bacteria. By giving this the day after chemo, we can keep the immune system high, and we can give the chemo more quickly. We can give it every 2 weeks rather than every 3 weeks. That's called dose-dense treatment. So we accelerate it, and probably people who've had the dose-dense treatment, when you're coming in every 2 weeks, it probably does feel a little bit like this lady on the roller coaster, that it's a bit quicker. So it can be psychologically tough every 2 weeks, but the end is nearer too. Boosting for this patient to dose-dense would be about another 8%. So we're starting to get well below 50% risk now. A brief pause for thought here. This patient's obviously high risk, and I did want to at this point comment on the fact that many people's cancers, thankfully most, are much lower risk than this. And so we find that there's actually a very small benefit from chemotherapies, and the side effects are the same as somebody who's got a high risk. So can we identify those few cancers in those groups that are pretty low risk that really need chemo and not give it to the rest? And that's where these cancer prediction signatures come in. And that's spotting that slightly different looking cancer that's actually more aggressive than all the rest. Cancer prediction signatures, we look at just 3 tests. We look at HER2, ER, and PR, as many will know. Standardly, these cancer prediction signatures look at dozens of different genes to try and get a better prediction and spot these slightly higher risk cancers. And you'll be familiar with some of these names. The earliest one was called mammoprint. It's not so popular because it has to be done on fresh tissue, so you have to decide you're going to have it before you have your operation. The most common one is Oncotype DX, the 21 gene recurrence score. These words at the bottom there, trials have been done to show you can reduce the number of chemotherapies you give and save people chemo by doing these tests. And Prosigna is being trialled in Australia at the moment with the Optimus study, and that one's a bit cheaper. Oncotype DX is about $5,000. It's not funded by government, though we have been campaigning, and BCNA has certainly been doing good work. And we hope to get it in due course, because some people who don't need chemo, we can show that and avoid it. So coming back to our case, the lady was also HER2 positive as well as ER positive. These show what we look at under the microscope. The brown staining is the HER2 protein, the chemical on the outside skin of the cell, the membrane. And you can see some people are 0, some people are 1 and 2, and those are all low-risk cancers, but also don't benefit from hitting that HER2 protein. The 3+, the really dark one over on the bottom right of your screens, that's a HER2 positive case. About 10% of people in WA, actually lower than the rest of Australia. And we give Herceptin was our first drug. It's an antibody. It's an immune molecule designed to stick to HER2. And it sticks on the outside. The antibody is the yellow Y-shaped thing here. And they are actually Y-shaped on the microscope as well. The two bits of the Y stick onto the target. And the other end of the Y, the stem, attracts immune cells to the area. And this both gums up the HER2 signaling system and switches it off, and cancer cells die. It also can attract immune cells to the area. This is what happens when we block to that. These are trials giving Herceptin or trastuzumab along with chemotherapy, and these are the risk reductions we saw. Now, some of the top two are lower benefits than others. One of them knocked about a third off the risk, the other only about 10% off. Compared to the bottom, it knocked about half off the risk of the cancer returning. And what's the difference here? Well, that was when the Herceptin was given with chemotherapy. So unfortunately, it still means we have to give chemo. Some people say, oh, this Herceptin is really good. Can I leave chemo? The government don't fund Herceptin without chemo, and this is why, because Herceptin both helps chemo work and vice versa, so you get very much the best results if you do have a bit of chemo. So we do have to keep it in to get the best results. For this patient, about 13% from trastuzumab. So I think we're now up to about 80%. We're also now doing a bit of testing the sensitivity of cancers. It's more and more we're doing this, particularly in HER2 positive cancers. Many people now be offered neoadjuvant treatment where you get chemo before your surgery, and then we shrink down the cancer, then we do an operation. Now, this can give you a smaller operation. That was the original purpose of it. However, now we're also able to see how well the cancer shrinks and then decide what treatment we give after, and we may give different things if the cancer shrinks well to if it doesn't. And the Catherine study, we've got a new type of Herceptin that's got a chemotherapy molecule attached to it that I'll be talking about a little bit in the other session. And so the Catherine study, people had this standard chemotherapy like this lady's having with Herceptin. They then had their operation. If the cancer was all gone, not a single cell to be seen, they just finished some Herceptin and that was it. If there was cancer left, though, they got this new souped-up Herceptin with the chemo attached called TDM1. And it was found that if you do the math and look at offering that tailoring system versus just giving everybody treatment after their operation, you reduce 17 in 100 events down to about 10. So again, you're getting on towards halving risk again. So by giving chemo before surgery, this lady would get about 9%, and I think this takes her up to about 85% risk. 85% chance of no cancer return. And we've still not come to estrogen yet, so many people have had tamoxifen or other similar drugs. And this is one of the big original studies with tens of thousands of women between all the trials, showing that tamoxifen knocks a big chunk off breast cancer mortality, even bigger chunk off breast cancer return, meaning people don't need more treatment even if it's still curable on return. And tamoxifen for this patient adds about 7%, mainly because our risk is now low. And then finally, you're familiar with the other type of anti-estrogen, the letrozole and nastrozole, exemestane. They're aromatase inhibitors. Tamoxifen stops estrogen working, whereas the aromatase inhibitors prevent estrogen being made. And so there are lots of comparisons looking at aromatase inhibitors to tamoxifen. We made it real complicated. We used to comparing one to another, giving half of one and half of the other compared to tamoxifen, or adding aromatase inhibitors on the end. And we found that aromatase inhibitors are slightly better than tamoxifen, but if you get bad side effects from aromatase inhibitors, tamoxifen is almost as good, so you're best to change for quality of life. And we've also found that extending, and to answer the question from earlier, there were studies going from 5 to 10 to 15 years and then coming back to 7.5. It looks that for the maximum benefit is around 7.5 years of treatment. If you're a low risk with negative lymph nodes and a small cancer, probably 5 years is very little difference to 7.5. So those people, we look at how the side effects are. And for that, it's 6%. And this patient actually has about 6% risk remaining on the graph. That's not working very well here. So that brings me to the main sort of Q&A. It's now Q&A time because I've gone far too long. I've got a little bit about new treatments and surveillance as well, which I might cover quickly after. But I'll stop for any questions about this briefly, and then I'll cover anything that's coming soon. And one of the questions I'll cover in the coming soon is, what about if I'm triple negative? What if my cancer is triple negative? Chemotherapy have these benefits, but Herceptin, other HER2 things, anti-estrogens don't help. So what are we doing there? And I'll be talking about that in a minute. Okay, and we can do. Cool, yeah. My apologies for that shocking time management. So, coming to an oncology department near you, things that have been proven that we're either looking for funding or funding's been approved but hasn't quite arrived yet. So drugs called the CDK4/6 inhibitors we're using in advanced breast cancer. We're now about to start using them in early breast cancer. Immunotherapy, what about immunotherapy? And I'll talk a bit more about that in the other session. But is immunotherapy any good for breast cancer? And then finally, the PARP inhibitors, those drugs that are used in patients, particularly with BRCA genes. So the CDK4/6 inhibitors, these are given alongside estrogen blocking treatments. We used to think of estrogen as a road to growth, and if we blocked it, we should cure everybody. And we found that though the control was good, we cured a few people with advanced breast cancer. It wasn't most people. We've now learned that the road is more like this. So you kind of move from Bunbury to Perth, or from Perth to Sydney, really. And we've had to deal with this complexity. So, and we're now blocking some of those side roads. Tamoxifen and aromatase inhibitors on the main road, but we're blocking the side roads. And one of those blocks, the CDK4 and 6 protein, is one of those side roads that can still allow growth. We're now using inhibitors, and we've now in early breast cancer, we've got 2 trials showing that these drugs improve the chance of breast cancer not coming back still further. Natalie, this was just announced last week, knocks about a quarter off the risk of in relatively high risk estrogen-driven breast cancers. And then the Monarchy, which is it was about a year older, so a bit longer out, that knocked about a third off. So that patient with a 6% risk, she may go down to about 4% because she's not much risk left. But people with a high risk may get more benefit. So abemaciclib, which is the Monarchy, was approved by the government for funding, and we should start giving it soon to people at high risk. Immunotherapy, I'll just mention briefly how immunotherapy works. I haven't really got time to go into that particularly, but what we got here on in this picture, the yellow thing is a tumor cell, and the blue thing is a cancer-killing lymphocyte, an immune cell. And they recognize cancer cells by funny-looking proteins due to the mutations in the cancer cells on the outside as foreign. However, cancer cells often also have this blue system, which is a self-marker, and the lymphocyte also recognizes that, so your lymphocytes don't go around killing your normal tissues. So if cancers have this blue system, it stops the immune system killing them. And with immunotherapy, this is just showing the second picture of the last slide, what we do is we give antibodies which block that blue system and stop the immune system thinking of the cancer cell as a friendly cell or as a self cell, and they'll kill it. Immunotherapy is so good it won the Nobel Prize for Medicine about 5 years ago, and you have to save a lot of lives to get a Nobel Prize in Medicine. It's not just a clever idea that seems to be working, you've got to save some lives. Unfortunately, though the patients that respond, melanoma's the tall graph, that's about 50%, and it goes down to triple-negative breast cancer, about 8%, and estrogen-sensitive breast cancer is only about 3 or 4% responses. So immunotherapy has not been as good in breast cancer. However, we have found that if we can detect that blue system on cancer cells, and that's mainly in triple-negative cancers, this study with pembrolizumab and immunotherapy was given to women before their surgery along with chemotherapy, and that is the first study that's really shown a benefit there. And we saw that the complete disappearance cancer with the chemo rose from about a half to about 2/3, and there was a drop of about 8%, there was a rise from being cancer-free at 3 years from 76 to 84%. This has not yet been around long enough to show there's a survival benefit, so this is not yet funded by government, but it is available on an access scheme where you pay part of the cost. And finally, PARP inhibitors, particularly in people who've got BRCA gene damage. These have been shown to help also in early breast cancer, and we're still waiting for funding there. Usually if a cancer cell gets damaged to its DNA, that DNA can be repaired by either the BRCA gene, BRCA protein, which is a repair gene, or PARP. But in people that have a BRCA gene in their family, that means their BRCA doesn't work. We found now if we inhibit the other system, we can kill cancer cells, because once their DNA is damaged and they can't repair it, and they've already got pretty ropey DNA, then we can kill them with PARP inhibitors. But you do have to have BRCA not working. And there are 2 trials in early and late breast cancer now, and the early one, Olympia A, knocked about 7% off the risk of cancer return at 4 years. So I just finally cover early detection, because there's quite a lot of questions about what tests people should have. And then I'll pause stop for questions. So what about monitoring? Lots of people ask, should I be having scans? Should I be having blood tests, tumour markers, all of those things? If I've had breast cancer, shouldn't we catch it as early as possible? We've done a lot of trials, the truth is, and we use what the trials showed made a difference. And so far, chest x-ray, the simplest x-ray, CT scans, more radiation, more detail, PET scans, a longer scan, about the same radiation as a CT scan, but more sensitive. We've done trials, and certainly chest x-rays and CT scans have shown to make no difference to the survival of people with breast cancer. We do them regularly when people are well and there's no concerns. And PET scans haven't yet been trialled, but looking at the result from CTs, it seems unlikely PET scans at this stage are going to make a difference either. What about blood tests? Well, doing tumour markers in breast cancer also wasn't sensitive enough. By the time the tumour marker goes up, the cancer is a stage where the sensitivity to treatment is the most important thing. In, say, ovarian cancer, in bowel cancer, in testicular cancer, we do it because catching it earlier makes a bigger difference. Circulating tumour cells, you can pay to have those done, and they are under research, but there haven't yet been any circulating tumour cells, and we've done some of that research ourselves, showing that you can catch cancer usefully early. And finally, the most promising thing, I think, is circulating tumour DNA. It's not the whole cell. You look for little bits of abnormal DNA. We've got special magnification tests so we can detect a very small amount in a blood sample. We've now got some trials going on seeing if, firstly, you can detect tumour with circulating tumour DNA, and maybe you can predict whether preventative treatments worked with it. What we do routinely, though, we do physical exams, because we did when we studied 2,000 patients at Royal Perth. When we found lumps, almost everybody was cured when we'd found that. It wasn't common, but it was curative. We do annual mammograms because those either a local cancer return or those second cancers, we found the cure rate was very high. We do annual mammograms, and we do ultrasounds if breast density is high. We do bone density scans for health, particularly with aromatase inhibitors, because they can lower your bone density, increase the risk of osteoporosis. Tamoxifen increases your risk of osteoporosis a little bit if you're premenopausal, but actually in postmenopausal ladies, it actually improves bone density. And so we don't do them routinely there, and even we may switch to tamoxifen if bone density is a problem. And finally, we do genetic testing in increasingly large numbers of people looking for those BRCA genes in anybody who's relatively young, particularly with triple-negative breast cancers. So, and the final thing I was going to comment on is we do have a lot of research looking at this dormancy thing and the fact that breast cancer is coming back later. We're trying to find not just ways of detecting early those sleeping cancer cells, but ways we might be able to eradicate the sleeping cells. And we're just trying to find out what makes them tick and what keeps them alive in order to do that. So that's where research is at the moment. Okay, so that's what I have for you. So I'm happy to take any questions. And my apologies, I accelerated a bit through that. I was just very leisurely in that first bit. Yeah.
It always happens. It always happens. Thank you, Andy. Any questions? Hang on. What else do we need?
The talk probably mirrored the presentation for the talk. You're thinking, I've got 3 weeks, so you start doing a few cool things, and then you suddenly realise you've got a 1 week, you speed up a bit, and then you suddenly realise it's tomorrow, and you go like this.
Can I just ask you a question?
Sure. Mm-hmm.
Several years ago, 1996, I had breast cancer, and a few years down the track, I decided to contact a genetic researchers in Perth at King Edward as to whether I was a carrier of BRCA1 and BRCA2 because I have 2 daughters.
Sure.
In the questions they were asking me, why did you want to?
Yeah,
and
indeed.
One of the questions was, are you a descendant of Ashkenazi Jews?
Mm-hmm.
And the radiologist last year again asked me that question.
Yeah.
And so my question is, why have they done research on that?
Well, so I think that the Ashkenazi Jews are an ancestral group of people who have very high risk of BRCA genes, and also when you see the risk of breast cancer if you've got a BRCA gene, you'll see that there's a figure that's like lifelong risk is 60 to 90%, that kind of thing. In fact, some ancestral groups have a higher risk of breast cancer with a BRCA gene, even when they've got that gene change. So firstly, there's a very high rate of carriage of BRCA. It's in women that get breast cancer, they're also selecting a population. Only about 4 or 5% of women in WA have a BRCA gene, and we can select those by looking at age and so on. Whereas in the Ashkenazi Jew population, I think it's more like 20%. So it's almost you get breast cancer and you're Ashkenazi Jew, then that's why. And they seem to there's all kinds of other genetic conditions they're also prone to. Whether that relates to a small genetic population and it's a small population, then there's intermarrying, I'm not sure, but yeah. Yeah, but good question. Yeah, and they've got lots of in Israel. They've got lots of screening programs, particularly for that subpopulation. Yeah.
Any other questions? I've just got. One quick one for you, Andy.
Sure.
When you hear people say, "I'm in remission," like there's a lot of confusion about what people after treatment say. How do you, as an oncologist, explain to the person sitting opposite you about the 5 years, what that actually means for someone, and what cancer-free versus remission, like we know language matters?
Sure, yeah. It's a good question because it's a frequent question. Yeah, quite right. I mean, I guess the word remission means no visible sign of cancer. So for somebody with early breast cancer, usually you're put into remission by your surgery. Otherwise, you essentially don't have early breast cancer to a certain extent. So we don't use the word remission because everybody with early breast cancer is in remission. If you had late breast cancer where we're actually treating visible cancer and then it disappears on CT scans and examination, that's maybe a bit more useful concept of remission. Obviously, the important thing is being cancer-free, what that means. And people often, obviously, there's store set on 5 years and 10 years. And that's not because 5 years and 10 years is this sudden drop-off of risk or the risk is really high up until that point. We use 5 years and 10 years. When we're comparing, we do lots of trials, obviously thousands of papers a year. And if some people looked at 2.5 years and some people looked at 4 and some people looked at 5.5, we wouldn't know quite how they compared. So we have set times when we look at results of any one treatment or process to compare which are the best ones. So that's why 5 years has got this built importance. One thing I would say is we tell you your risk, and one of the problems with early breast cancer in explaining it is it's a numbers game. It's not about what do I need and what's going to do it for me. It's if we give you this, then less of people like you will have a problem. And explaining that, and then people often after complex numbers, and we keep it as simple as we can, say, but do I need it? We'll go, well, maybe not, maybe. We don't have a test that shows that. One thing I would say, though, we do give these figures at the beginning. Say your risk might be 20% of getting cancer back over the next 10 years. That's not, when you get to 5 years, it's not still 20%, it's probably 8%. So every day you wake up and there's no problem, then your risk is a bit lower than it was the day before. So some people have this sense of 20% for life, whereas by the time you're hitting 10 years, it's probably 3%. And your risk starts to be absorbed into the risk of other events and trucks and lorries and so on. Yeah.
This might be a bit outside of your realm, but I'm just wondering whether you've got any information about HRT and estrogen receptor positive cancer.
Oh yeah, I think I have a Q&A slide at the end there. Sorry, that question was on there. It's pretty much within my realm because I see a lot of people who have had breast cancer or on hormone related treatments have got problems. So HRT, the broad advisory, obviously, if you've had an estrogen sensitive tumour, there was a study called the HABIT study, Hormones After Breast Cancer, Is It Safe? Was what HABIT stood for. And it was estrogen-sensitive cancers, and there was shown to be a high risk of combined HRT, that's estrogen and progesterone, of getting breast cancer back. It went up about 3 times. So that's the basic figure that we don't do it there. One thing, though, that has been found is if you give estrogen-only HRT, and estrogen is way more complex than it sounds, it's not more oestrogen bad, less oestrogen good. If you give oestrogen only HRT, it doesn't increase the risk. It's only when you have the combined one with the progesterone only. Thing is about oestrogen only HRT is it's dangerous if you've still got a uterus, if you've not had a hysterectomy, because it increases your risk of endometrial cancer. So people have had a hysterectomy and they've got bad menopausal symptoms. We channel it through the menopausal symptoms clinic at King Eddie's, but we keep the dose as low as possible with oestrogen only HRT, and a study showed that that didn't increase the risk. The Swedes did that. That's kind of hormones. Depends on the symptom as well. If you've got vaginal dryness or atrophy, particularly if you're on tamoxifen, then local estrogen is probably safe, because the tamoxifen, the estrogen will just be higher in the vagina where it's needed, and tamoxifen will block it a little bit there, but it'll block the tiny amounts against circulation elsewhere. Maybe a slight risk if you're on a aromatase inhibitor, but it's not probably a big risk. That's that symptom. And then we have other non-estrogen treatments for flushes. There's 3 different drugs we use. We use one that's used for blood pressure, high blood pressure. We use one that's used for depression, and we use one that's used for epilepsy. All high doses for the original condition, and all of them have been shown to improve flushes if your flush is a particular problem. And there is a menopausal symptoms after cancer clinic at King Eddie's. It's one of only 2 in the world. The other was in over east, and the first one was here. Martha Hickey set that up, and then she went over east and set one up over there. So, though it does mean going to Perth, they may do teleconferencing, and anybody can be referred. It's a central service, and I learn a lot from them. I send my patients where I've not managed to sort things out for them there, and I learn other things too. Yeah.